Hi, everyone, and welcome to our FORE webinar today that's going to focus on policy and regulatory opportunities to address the opioid and overdose crisis in 2024. My name is Ken Shaskis. I am the program director here at the Foundation for Opioid Response Efforts. Just quickly going to go over the agenda as well as some logistics for the webinar today. So we have a great lineup. We're going to first start off with looking at federal levers addressing the opioid crisis from our Bipartisan Policy Center grantee. We're going to be looking at how to overcome potential legal barriers to a whole of government approach to overdose through our grant from Temple University in collaboration with Indiana University. We're also going to have a fireside chat. It's going to be led by our President Karen Scott with a fantastic panel of participants. And then we're going to reserve the last 15 minutes like we always do for a question and answer session from all of you. Quickly, so the webinar speakers today, we'll have our two FORE grantees, Michelle Gilbert, who's a senior policy analyst at the Bipartisan Policy Center. We'll have Nick Terry, who is the Hall Render Professor of Law and the Executive Director of the Hall Center for Law and Health at Indiana University McKinney School of Law. And then for our fireside chat, we have Regina LaBelle, who's the Director of the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Health Law at Georgetown University Law Center. And she'll be joined by Dr. Richard Frank, who's the Leonard D. Schaefer Chair and Director of the Schaefer Initiative on Health Policy at the Brookings Institution. So fantastic lineup for you today. Quickly, as always, our webinars are recorded and they're going to be available for viewing on our website shortly after the session ends. The slides will also be available to download, so don't worry about if you missed anything from the slides itself. Again, we will have a short Q&A session of about 15 minutes at the end of the presentations. Please use the Q&A box found at the bottom of your Zoom screen to submit any questions that you have throughout the session. So we can get to as many as possible. Check to see if there's a similar question first before you ask yours, and use the upvote function using the thumbs up button to move that one up so we know which ones are the more pressing questions that people want answered. Finally, at the end, when the webinar ends, there's going to be a brief survey that we'll be looking for your feedback as we look for other topics and things that you all are interested in for future webinar subjects. So quickly about FORE, I want to get to the presentations themselves, but about FORE, again, we were founded in 2018 as a private national grant-making foundation focused solely on the opioid crisis. To date, we've given out 102 grants worth over $40 million to nearly 100 organizations across the United States. And again, we very much focus on evidence-based solutions that address the opioid crisis with always patients at the center. With that, I want to move right into our presentations for today and introduce Michelle Gilbert, who's helping lead our project at Bipartisan Policy Center, and she's going to be discussing federal levers to address the opioid crisis. So Michelle, I hand it off to you.
Thank you, Ken. Hi, everyone. Great to have you here today. As Ken mentioned, I'm Michelle Gilbert. I'm a senior policy analyst at the Bipartisan Policy Center. I lead our addiction policy portfolio and have had the pleasure of working with the Foundation for Opioid Response Efforts for the past few years. Very exciting. Next slide, please. Just a little bit of background on BPC. We are a think tank based in Washington, D.C. We focus on finding bipartisan solutions to various policy issues, including economic, housing, energy, and technology policy. I work on the health program where we examine our nation's most pressing health policy issues. We work with folks across the political spectrum to find solutions and blend research and evidence with political and policy priorities. We direct those primarily towards federal stakeholders. I know we have a lot of great folks who we've worked with already, so great to have partners here. And our recommendations are geared mostly towards Congress and federal agencies. When our grants conclude, we also work very closely with our C4 organization, BPC Action, to implement these policy recommendations. And just this year, we've had several bills introduced that are based on BPC's policy proposals. Next slide, please. So just a little bit about our behavioral health work. We have published reports on behavioral health and primary care integration. We had a task force that went from 2020 to 2021 that Dr. Richard Frank was part of, and he'll join us later. We also have reports on crisis care, the non-clinical workforce, so primarily that peer support recovery specialists, community and community health workers. We've also focused a lot on telehealth and digital health, and of course the opioid crisis and rural areas in particular. And then most recently, just last week, we launched a youth mental health and substance use task force, which will explore a lot of great things related to youth substance use. Our addiction policy work has focused largely on financing and fostering a whole of government approach to addressing the opioid crisis. In our first two reports of a series of three, we tracked federal opioid related grant dollars and where they went. And Regina LaBelle, who you'll hear from later, supported those efforts. And then in a subsequent report, which FORE had funded, we convened a group of bipartisan experts and federal and former government officials looking at how those funding decisions are made at the federal level. And now that the settlement funds are starting to flow into states and localities, there's a real opportunity to use those funds to fill gaps in federal grant dollars. Next slide, please. So at the top of the list for Congress, there are quite a few holdovers from last year, and some of these present some opportunities for expanding access to behavioral health care. Primarily the spending package, which is a must-pass bill and includes line items for federal grant programs that are very essential to opioid use disorder care and access to treatment. If this is not passed or a deadline isn't adjusted again, that's when a shutdown will happen. So we're hoping that that isn't the case. The next holdover from 2023 is the Support Act, which would reauthorize many of the vital addiction services, policies to curb fentanyl supply and demand, and policies to improve the workforce, including the peer workforce. That's something BPC has worked very closely with various members on. And also legislation on children's online safety, which has bipartisan support and is something that both mental health and addiction advocates are very interested in as the fentanyl crisis continues to evolve. Next slide, please. In recent years, Congress has really taken steps in the right direction to address behavioral health broadly. Since 2024 is an election year, the success they've had may mean that Congress is content with their achievements. Nevertheless, these landmark bills that are listed here will provide some valuable funding to fill service needs. The first kind of big landmark is the American Rescue Plan, which passed in response to the need for more federal aid during the COVID-19 pandemic. And this resulted in more resources for formula grant programs, workforce development efforts, and community-based services. The kind of elephant in the room is that a lot of these grants will expire in 2025 if they aren't reauthorized. So I know that a lot of you are tracking on this and that there's a lot of interest from folks out in the community to get these to be sustained. The second landmark bill that I'll highlight here is the Bipartisan Safer Communities Act, which passed after the tragic school shooting in Uvalde, Texas. And this bill authorized additional resources for mental health and crisis care, including in schools. Last year's spending bill presented a lot of great opportunities for expanding the workforce. Through that bill, we saw the expansion of Medicare for licensed mental health counselors, and marriage and family therapists. We've also seen some key programs around strengthening telebehavioral health care. And most importantly, we saw that the X-Waiver was eliminated in the spending package. Finally, what I'll highlight here is the National Suicide Hotline Designation Act, which authorized the new 988 program that SAMHSA is running. And this has been, in its first year and a half, a real asset for first responders across the country. Next slide. But there's still room to build on progress. So some of the issues here are the top issues that I've heard in conversations with policymakers in the federal government. A lot of folks really interested in addressing youth substance use, particularly sales via social media, looking at the role of schools and getting there to be prevention and treatment that goes beyond kind of those universal prevention programs we've seen historically. We're also hearing a lot from lawmakers about the need to further address the fentanyl crisis. A lot of folks who are interested in the supply and drug sales, as well as kind of thinking about that demand aspect and how crisis response resources and harm reduction approaches can be applied. Also thinking about enhancing the care delivery system. We're, unfortunately dealing in a reality where under 20% of folks are getting access to treatment, and for any other disease other than addiction, this would be a real travesty. So we're trying to find policy avenues and helping lawmakers who are committed to finding avenues for further expanding access to care and ensuring that people can get into treatment and into recovery. So this includes, policies around workforce development and teleprescribing and digital care. Finally, this is maybe a little wonky for this audience, but the Office of National Drug Control Policy is also up for reauthorization. And we're hearing from lawmakers that, that there's a real commitment to this office and for kind of tracking on expiring grant programs from the American Rescue Plan and from the Support Act. Next slide, please. So BPC has been working closely, as I've mentioned, with a lot of folks, and we've had some real traction on the Hill, particularly with the Support Act. We've played an instrumental role with FORE support on putting together an issue brief with provisions relevant to the Support Act, and this has been used to educate staff and members on the policy directions and priorities. So to name a few, these include strengthening the peer support and recovery specialist workforce, looking at improving Medicaid coverage for justice-involved individuals, both pre-trial and post-release. We've also been supporting folks in finding ways to reauthorize grants that fund key services and looking at ways to streamline some of those a little bit more. And finally, ensuring that data are actionable and help to understand the scope of both mental health and substance use issues across the country. Next slide, please. So turning to the administration, compared with Congress, I think an election year presents a different framework for the administration. And I think they'll choose to highlight and showcase some of their achievements from the past several years. The main thing with the administration is there's such a strong commitment to behavioral health as part of the Unity Agenda that was unveiled in 2022. The administration's also been very committed to looking at evidence-based teleprescribing and conceptualizing what some of those rules should be to expand access to care, but safely. The administration has also, and really CMS has also been working towards expanding access to addiction services across the continuum of care. Just last week, CMMI at CMS rolled out a payment model that looks at ensuring reverse integration. So making sure that primary care services are available in behavioral health specialty clinics to ensure that those very high-risk patients have access to some of those physical health needs. And then also, I mentioned this already, but coverage for licensed mental health counselors and marriage and family therapists has been top of the list for them. And we'll hope that peers could be next. Okay, next slide, please. So stemming from our broader portfolio, BPC has supported the administration in a couple of different things, including developing a data dashboard on non-fatal overdoses. The White House introduced this just about a year ago, and this has been really helpful for looking at county level data that come in almost for government almost real time on tracking the scope of non-fatal overdoses across the country. We've also joined advocates in helping to eliminate the X-Waiver, and that was implemented, as I've mentioned, in late 2022. We've also worked quite heavily in opportunities to expand telebehavioral health care and looking at opportunities to evaluate some of the impacts of the telehealth flexibilities from the pandemic. We've explored opportunities to improve the SOR grant, helping the GAO write a report and put their information together on an SOR grant report that they're putting together, and supporting SAMHSA in every way that we can. We've also helped with improving Medicare coverage for unlicensed behavioral health providers and helping to develop the CMMI model on reverse integration. Next slide, please. And that's it. Thank you, everyone.
Thanks so much, Michelle. All right, with that, we are going to move on now to our second speaker. This is Nick Terry, who's the Hall-Render Professor of Law and Executive Director at the Hall Center for Law and Health at the Indiana University McKinney School of Law. He has been working with Temple University on a FORE grant that focuses on whole of government approach to overdose. So with that, I'm going to hand it over to Nick.
Thank you, Ken. Thanks to Ken and Karen and everyone at FORE for supporting our work and for this opportunity to present. Slide, please. I have no disclosures, so we can move on swiftly to the next slide, Ken. Although likely to be well known to this audience, we owe it, I think, to those who are suffering to reflect on the terrible impact that OUD and SUD have had on the lives of our fellow citizens. We now find ourselves taking sort of cold comfort in an apparent flattening of overdose deaths to only about 112,000 per year. Slide, please. Overdose deaths are dominated by synthetic opioids, and increasingly they're being used as building blocks for ever more deadly cocktails. Slide, please. And it's not just the deaths, but the incredible suffering by millions. Indeed, the national life expectancy figures showing a staggering decline now clearly reflect the impact of the diseases and deaths of despair that we are trying to address. Slide, please. And so a difficult question, or a couple of questions arise, which is, well, don't we already know what to do? Don't we know how to intervene and make a positive difference here? The 2016 US Surgeon General's report provided an extraordinarily thorough and essentially irrefutable diagnosis of the country's drug problem. It also just suggested a possible inflection point for drug policy, a transition from drug control policing to an embrace of public health and healthcare policies aimed at harm reduction, prevention, and treatment. Yet the war on drugs continues, bringing with it law enforcement overreaching, disproportionate sentencing, overwhelmingly unequal consequences for people of color, and collateral consequences that linger long after incarceration. We've spent more than $1 trillion on the war. Even as drug prices drop, the illegal drug supply gets more dangerous and the deaths keep going up. In the last decade or so, we haven't only documented the structural determinants of substance use, such as policing, race, poverty, educational opportunities. We now also recognize the role that social determinants, including environment, poverty, transport, food security, all play, heavily influencing both resilience in the face of addiction and thereafter the odds of successful treatment and recovery. Knowing all this, why haven't we made more progress? Clearly, we face a systems problem, and it's a complex one. Slide, please. So our project was to try and pick at this systemic problem, and we focused on a whole of government lens. Because of the systemic nature of wicked problems, the authority to address them tends to be distributed across multiple agencies, either at one level of government, which we term horizontal, or across different levels of government, which we term vertical whole of government, or of course, both. Whole of government should be the counterweight to governmental siloization. However, responses to OOUD have too often demonstrated how decisions made by one agency or level of government actually can frustrate the work of others. It's been noted that whole of government requires, quote, horizontal and vertical coordination in order to eliminate situations in which different policies undermine each other, to make better use of scarce resources, to create synergies by bringing together different stakeholders in a particular policy area, and to offer citizens seamless rather than fragmented access to services. This in turn requires agencies not only to work cooperatively, but also to think coherently about how the levers they can move interact with the levers of the other agencies in the system, and the evidence of what actions produce harms and what actions prevent or effectively prevent them. Now, there's always room for optimism. My fingers clearly are crossed that the new HHS Behavioral Health Coordination Program, funded in the appropriations legislation, is a positive start. Equally, as realists, we recognize that our call for an aligned whole-of-government approach will not sit well with many who view government as the problem rather than the solution. Slide, please. So those of you who've done your due diligence and read the myriad of state and federal policy reports from the last decade will be familiar with the traditional drug pillars. It's projected as a comforting model, 4 equal stone balusters supporting a coherent drug policy edifice. Indeed, many government agencies and commissions have endorsed policy frameworks built on this set of supposedly mutually supportive pillars: harm reduction, prevention, treatment, drug control, policing. However, these pillars are not equal. Just compare, for example, the budget for drug policing with that for harm reduction. Frequently, they are also oppositional or antagonistic. Indeed, many of our drug policies are causing the very harms that other policies seek to address. Part of the so-called public health paradox. Taxpayers pay for the drug policing and incarceration that cause inequities, and then pay again through healthcare and harm reduction, trying to reduce them. Slide, please. Once we accept the criminalization of drugs and drug users is not a supportive pillar, it's possible to suggest a very different model. The key component, obviously, is decriminalization. The broader transformation must be in removing impediments to harm reduction in healthcare. However, and here I glance at Oregon and San Francisco, amongst other places, it is crucial to understand that ending the harm of criminalization must be accompanied by building a new approach that does better. As we move away from warehousing drug users in prisons, with the minimal treatment they receive there, we must invest in the comprehensive treatment, harm reduction, and safety net services they actually require. Slide, please. Even when policies across horizontal, i.e. horizontal, and between, i.e. vertical levels of government, are not outright antagonistic, frequently they are seriously misaligned, causing friction. Whether oppositional or misaligned, these strategies and the laws or policies through which they operate must be transformed. The sad poster children are syringe service programs. There is an overwhelming evidence base supporting SSPs. Yet federal certificate of need-like requirements for funding and the appropriations rider prohibition on federal monies being used for actual syringes highlight horizontal federal misalignment, while direct state prohibitions, indirect paraphernalia laws as structural barriers to using SSPs, and states permitting local vetoes illustrate the vertical problems. So what explains, slide please, all the sand in the gears, if you like? Well, clearly there is some low-hanging fruit. Effective drug policy is hugely dependent on us solving another wicked problem, many wicked problems. For example, access to affordable care for the millions at the greatest risk. There is always room for improved agency cooperation. Look at DEA, DOJ, HHS, SAMHSA, FDA, and you do see examples of horizontal misalignment, particularly those that played out and still play out to an extent over OAT regulation. Vertically, we see federal-state misalignments over issues such as Medicaid expansion or state-local home rule arguments that lead to NIMBYism over the citing of SSPs and other harm reduction. In our federal system, central government blankets attention because of its visibility and how it sets and funds broad policies for the country. But most of the actual lifting on federal policy is done by state and local agencies, which take federal dollars and put them to work. States, and through them, localities and nonprofits, are also dependent on multiple funding streams, not only in their sources, such as federal or state, but also their type, whether mandatory or discretionary, and their stability, such as whether the funding is consistent or is just provided through episodic grants. That is why the work of the BPC on braiding frameworks, I think, is so important. While I think we would add to that maybe the necessity for some, quote, pair of last resort model, as used in the Ryan White HIV/AIDS program, which could well complement those braiding frameworks. Slide, please. So the core of our project was to identify the legal barriers to vertical and horizontal alignment. We identified 84 legal law policy barriers across federal, state, and local governments. We categorized them against the 4 overall policy domains of drug policing, harm reduction, healthcare, and social determinants. I'm going to, because of time constraints, I'm just going to concentrate on harm reduction and treatment with a couple of observations. Slide, please. Harm reduction measures are particularly hobbled or blocked by the moral defect narrative and the punitive drug laws built to express that disdain. Our priority must be to remove or minimize the federal and state laws and policies that make harm reduction strategies more difficult or even outright illegal. I've already addressed the horizontal and vertical barriers to effective SSPs, but there are other examples. The still nascent idea of, in this country, of overdose prevention center services, OPCs, face a sort of reversed vertical barrier compared to SSPs. With regard to OPCs, while some states and municipalities are interested in trialing them, the federal government continues to stand by its crack house law, making them unlawful as a matter of federal law. Naloxone availability can face even more nuanced barriers. While the FDA finally made the drug over the counter, rendering state standing orders unnecessary, although I would add not necessarily fixing the question of affordability, That doesn't mean that naloxone is generally available. For example, there's a Massachusetts statute that actually requires pharmacies to, quote, maintain continuous supply of naloxone rescue kits or opioid antagonist medications, unquote. Yet research suggests that very few pharmacies in that state do indeed maintain those supplies. State governments need to move beyond the worst of the war on drugs, for example, by eliminating drug-induced homicide charges against street-level dealers and people sharing drugs with other users. The states need to address the legal rules that create persistent barriers to harm reduction, such as state drug paraphernalia laws that impede federal-funded initiatives such as naloxone distribution, fentanyl test strips, and SSPs. State executives also must ask themselves whether they are making sufficient progress on structural barriers, such as the attitudes of local prosecutors to people who use drugs, the links between homelessness and drug taking, and efforts to reduce stigma. State governments must also find a consistent institutional home for harm reduction. There must be aligned appropriations from the federal and state budget, and as Michelle noted, the opioid lawsuit settlements that are both big and flexible enough to allow states and localities to construct a true harm reduction system, one that is tailored to local needs, but with a firm floor of decriminalization, destigmatizing, non-discrimination elements that nudge states towards a public health and non-punitive approach to OUD. Slide, please. Secondly, healthcare. Access to the most effective medications and treatments is still hampered by the stigma and regulatory structures that are the legacy of criminalization. Buprenorphine overregulation may have ended, finally, but when will we end methadone overregulation and the monopoly enjoyed by opioid treatment programs? And of course, substance use healthcare is a reflection of all that is problematic with healthcare writ large. Health inequities, access, cost, fragmentation of services, poor care coordination, and ineffective treatment parity. Congress must finish the work it has started in redesigning healthcare to elevate behavioral health away from its separative, stigma-driven historical antecedents, and finally build an integrated care model, strengthen parity laws, provide the Department of Labor with enforcement powers with regard to parity. Meanwhile, CMS, Centers for Medicare and Medicaid Services, must strengthen the regulation of health insurers to increase in-network coverage for behavioral care. Slide, please. So there are opportunities. What sort of progress are we seeing or are we likely to see? First, long-term, or if you prefer, sort of more of the big picture. For me, the two major questions are, one, can we make progress on harm reduction given the current state of criminalization and policing? Secondly, can we make progress on treatment without fixing structural and social determinants? I continue to worry that the answer to both is no, in which case we will continue to take one step forward and then two back. And it could get worse. At the moment, we have a harm reduction technology in naloxone that is effective against most dangerous substances, and a treatment technology in methadone that has a proven track record. However, as the synthetics get stronger, polysubstance use flourishes, or worst case, a new technology-resistant drug emerges, then our current policies and funding based around naloxone methadone may well become outdated. Next, sort of medium term, much of which Michelle so ably covered. Substance use, like mental health, has attracted a considerable amount of bipartisan, bicameral support over the past decade. 2018 Support Act arguably was the peak of legislative action and financial support. I worry, however, that it was treated as a mission accomplished moment. More recently, its underlying consensus, law enforcement interdiction aside, seems to have gone missing. The Support Act sunsetted in September, and I don't see that much energy or ambition in its renewal. I think there's less so in the Senate than in the House. I hope I'm wrong. The Consolidated Appropriations Act showed some glimmers. The X-Waiver gone, some recovery housing, parity enforcement being looked at. But it's difficult to see much more legislative progress during an election year that potentially will redefine chaos. And inevitably, the potential for a change in administration raises questions about the future of key programs, such as the health insurance marketplace subsidies, Medicaid itself, our key strategy with regard to healthcare and substance use, and other aspects of the safety net. Third, short term. Clearly, the Biden administration had some wind in its sails in 2020 and was able to regulate some improvements to harm reduction and treatment based on the natural experiments observed during the public health emergency. However, with the end of the PHE funding, there have been some backsliding. For example, some 15 million persons have lost Medicaid coverage. Although luckily, hopefully, that has been softened slightly by the American Rescue Plan, Inflation Reduction Act, individual market exchange subsidy reforms. Given long and medium-term problems with legislative progress, likely we'll see more regulatory changes, more of the same. An example being the recent regulatory changes to prior authorization processes followed by insurers. And just last week, CMS announced their innovation in behavioral health, their IBH model, funding Medicaid, Medicare demonstration projects in community health practices to focus on care integration and management. And as I continue sort of being a downer here, I have to note that they're only funding 8 demonstration projects. Yet this is exactly the sort of strategy that we think that the evidence suggests would really work. So we need to fund a lot more than 8 of them straight off the bat. Overall, the politicization of inequality, healthcare drug policy, and the stigma surrounding drug users and those who treat them suggests we'll be facing a slow and likely decentralized state-by-state process, while in some places, just turning down the heat on the war on drugs may be a victory. Slide, please. So my great thanks for this opportunity. My thanks to all the members of our team at Temple and Indiana, and the members of our distinguished expert advisory committee. Slide, please. And if you click on the QR code here, you will be able to download our database of shovel-ready legal actions and read the white papers that we wrote in support of that, and hopefully send us lots of valuable feedback. Thank you.
Nick, thank you so much. And hello, everyone. I'm Karen Scott. I serve as president of the Foundation for Opioid Response Efforts. Thank you, Ken, Michelle, and Nick for launching off this webinar discussion and really injecting a lot of interest, a lot of great comments from the audience, and good challenges for us to continue in terms of this discussion. We're going to continue it now by welcoming Regina LaBelle, who's Director of Addiction and Public Policy Initiative at Georgetown University Law Center, and Richard Frank, who's the Director of the Schaefer Initiative on Health Policy at the Brookings Institution. I think, yeah, we will just take down the slides and launch into a discussion. In the meantime, for the audience, we welcome you to continue entering any questions you have into the Q&A through the Q&A button on your screen, and we will turn to those in about 15 minutes. So Regina, Richard, thank you so much for being with us this afternoon. Wonderful to see you. Michelle and Nick have launched the discussion and set up a few of the challenges as they see them for this coming year. And I'd like to start by inviting each of you to both give the audience a little bit more of an introduction about your work, but then talk about what you see as your hopes for what should be our high priorities for 2024 in terms of national policy to address the opioid and overdose crisis. And maybe if you think it's different between what's likely, what should be those priorities, and ideally what realistically might happen across 2024, if you see a distinction there, that would be great to get us started on this part of the discussion. So Regina, I'll turn over to you first.
Sure. Thanks so much, Karen, and to FORE for holding this webinar to discuss this. And I also I want to commend people who work every day on these issues. You know, people in the federal government who work on this. I served in the federal government in the Obama administration for 8 years and served in the first year of the Biden administration, establishing the first set of drug policy priorities. This work is really hard. And it is hard on many levels because of stigma, but also because of entrenched interests and really a lack of urgency about it. So I'll just briefly say, you know, in my time in the Biden administration, I was acting director of the White House Office of National Drug Control Policy. And I really was very fortunate to be able to work with across the federal government to get a few things done. And, you know, when we walked in, I walked in the afternoon of Inauguration Day and said, I want to do a couple things. And one thing that I said that I want to do is make sure that harm reduction is a pillar of federal drug control strategy. That seems like it might be really easy to do, but it's not. And, but, you know, what I think if I could wave a magic wand and get something done this year, obviously it would be to make sure that the telemedicine rule, telehealth rule is finalized and is, you know, is good. And then secondly, that the methadone bill is passed, MOTAA. And then lastly, that Congress, which has passed 28 bills this year in this Congress, 118th Congress, it gets a budget that fully funds its priorities, because an authorization bill is not sufficient. It needs the budget behind it. So that's what I would do. And I'll let my partner in crime here, Richard, speak.
Thanks, Gina. Richard? I think you're on mute. Richard.
Thank you for inviting me, and I'm glad to see you all, Regina, Karen. Well, I'll jump in where Regina left off, which is I too spent close to 5 years in the Obama administration and spent a lot of time working on opioid use disorders. One thing that I want to sort of reinforce that Regina said is that this is hard, and it's and I would say in the Obama administration and probably in the Biden administration as well, whole of government was a serious undertaking, and I think that what is important to remember is that this is a really big, complicated, messy country, and that finding solutions to what I think Nick's called the vertical whole of government problem is not a matter of the federal government dictating. It has a lot to do with trying to meet folks where they live. And where people live in different parts of this country is really different, particularly when it comes to dealing with addiction. And so I think that's always important to bear in mind, because you can waste an enormous amount of resources trying to get people to do what they're not inclined to do, instead of trying to figure out where you can move the ball forward in the context in which they live. To me, my sort of first priority would be trying to get us from having a good day when we treat 10 to 20% of the problem to one where we treat 40% of the problem or 50% of the problem. I think that we need to improve our ability to engage, identify and engage people in treatment. And I think that if we don't make real progress on that, we'll never get ahead of this problem. And I think there's been an underinvestment both on the research side, but also on the policy side in trying to figure out what kinds of outreach efforts we should really be supporting. And so my hope is that we start to sort of seriously engage food programs and shelters and the various education systems and drop-in centers and the like, and continue to invest in mobile clinics and mobile treatment, because I think that is our best bet, at least from what the evidence I've read, on starting to do a better job engaging people. My other hope is that states will and communities will think very seriously and very strategically about how to use settlement dollars. We now have a set of grant-driven authorities. We have the Medicaid program, which has made big strides towards dealing with substance use disorders relative to at least when I started in this field. And now we have settlement dollars, and they each can be used in different ways to accomplish different things. And my concern is that they're all being thrown at the same problem together. And I think that I have at least had the uplifting experience of talking to at least a couple of states that are taking a very strategic look at, how do you best use each set of dollars? Do you build capacity with grant programs? Do you pay for recurrent costs with Medicaid? And then do you do innovative, hard to fund things that don't fit with the other two programs using the settlement dollars? And I think that figuring out how to do that well and working with the states to do that could pay enormous dividends. My last wish is that we take accountability much more seriously than we have. As I look at particularly our accreditation systems, especially on the residential side, as we look at some of the state licensing system, as we look at the enforcement of the waiver programs and the deals that were struck there, I think we're very, very far from the optimum. And I think that taking that set of accountability measures seriously can help us do a much better job with the people that we are treating and the dollars we are using, putting to work on all this. I'll stop here.
Richard, thank you. Regina, thank you. I want to come back to a number of those points, but Richard, just to follow up on that last point on the accountability, you were also part of the BPC opioid task force project and the report that that we helped support in 2022, and there was a piece in there. There was some focus of you and your colleagues on data and accountability. And I just wondered if you might want to could comment a little bit more on, what would that look like? Where do we start in terms of some of those steps towards accountability?
Well, if you look at sort of some of the secret shopper studies that have been done, you have an enormous number of facilities that actually prohibit the use of evidence-based treatments in the form of MOUD, getting accredited by JCHO and COF. That's just unacceptable. I think there isn't enough attention in enforcing those provisions under the waiver programs. And I think that we all need to take the institutions that we have that are in charge of doing this, that have, frameworks for doing this, and get them to redouble their efforts. And I think we could actually make some progress by doing so. And that, takes investigation, it takes oversight, it takes, aligning the policies and procedures with what we know is good science.
Right, thank you. Regina, to come back to you, you mentioned that you served as acting director of ONDCP the first year of the Biden-Harris administration. So that included putting out the first drug policy agenda. And as you said, making sure harm reduction was a part of that. Just wondered if you could comment a little bit more on that, on the development of those agendas and what you've seen as sort of through the themes that have carried through over the last couple of years and how that might lead us in the next year.
Sure. So that, was I think it was seven points that we worked on through the transition so that we would be ready because it had to be sent out in April. And so I think, there has been progress made to make harm reduction more central. We're not where we should be, obviously, but that, we did make some strides with, moving from just considering fentanyl test strips to drug checking generally, to looking at, treatment in corrections. It was embarrassing to me as a federal government employee that the Bureau of Prisons did not provide medications to people who are incarcerated. The federal government should be a model for that. And so now that's starting. There's been a lot of litigation. I want to pick up on what Richard said about accountability. I mean, the American Disabilities Act is a really powerful tool. Yes. And we have been really fortunate to have a Department of Justice, the Disability Rights Section, that's using it in the way it should be. And EEOC is using it in the way it should be, so that we have more enforcement actions nationwide. I mean, you simply can't, tell someone they have to get off of their medications for opioid use disorder in order to receive a public service. It's just illegal. And so we're, that is something that is expanding nationwide. We started focusing on in the first year. And, my concern is obviously that we're in this election year where there's going to be a lot of status quo. So we have a lot of rules out there that have been issued, and now we have to make sure they're finalized, get them finalized so that they can withstand any political forces. So usually in election year, you start looking at what the executive branch can do. And there are many things that can be done in all of these arenas to build on the work that started in 2021, 2022.
Thank you. That's helpful framing again, where the real work can be in the focus and to get to make sure we don't lose ground in the coming year. Richard, you noted the gap between the data points on the gap between those accessing treatment for OUD and those who might need it and benefit from it. That's certainly one of the data points at the foundation that we track very closely and we think about in terms of some of the projects we fund. A couple of the others, which were mentioned briefly earlier in the webinar, is certainly the continued sharp increases in overdose mortality among Black and Indigenous individuals, as well as what we're seeing in terms of a sharp increase in overdose rates among adolescents. And even though the absolute numbers there are small, it's been a sharp and significant increase in the last couple of years. And while at a national level, we think about the entire population and the proposals that really blanket and can reach everyone, how do we at the same time think about making sure that those policies are reaching, those that are most impacted right now? Regina?
Regina, you want to go? Go ahead.
I'm sorry, go ahead, Richard.
No, you can go ahead.
Well, there was a question that was asked in the Q&A.
Oh.
Can I answer one of the questions?
Sure.
So a lot of what we have focused on here has been about, US responses, and there's the political environment that we're in right now is focusing a lot on the border. And I mean, there are a couple things that I think that it's important as we look at this year and what can be done is that, we know a couple facts that the drugs that are coming across the border are not being brought for the most part by the people who are held at the border. They're brought by US citizens. But also, I think we are all in this together. We are seeing an increase in fentanyl overdose deaths in Mexico. And so there is an effort to expand access to evidence-based treatment across the border. So when we think about those cross-border policies, it's not just, certainly the supply piece is important, but we also need to think about how we can share. We don't have perfect systems, but we have, the largest research entity in the world on drug use, NIDA. So sharing that expertise across border, and particularly in Mexico and Latin America, can really help also resolve some of those issues that kind of drive some of the trafficking that we're seeing. Sorry, Karen, I took us in a different direction.
Okay.
So Karen, I'll take your question now. So yeah, I guess there's three observations I'd make. The first one is, there have now been a bunch of randomized trials, which I'm sure you're aware of, that make it clear that treatment goes a lot better when it's delivered by somebody who looks like you. And I think what we've seen in some of the successes around bringing more nurse practitioners and physician assistants into the treatment fold, if you will, that has happened because of CARA. In a sense, you've seen some inroads both in rural areas, but also in disadvantaged communities that have helped. So that's the second piece. So one, you look like people, you increase the workforce in areas where you can do it more quickly, and you have a better chance of getting people that are more diverse. And then third is, I think those outreach efforts that I was talking about, you can target those in a way that will really go after the populations and communities that you were exactly talking about, because they're the ones who are least trusting of walking up, knocking on the door of a clinic or a physician's office and claiming to have a problem. They're much more likely to engage in their communities, near their homes, in environments that they're familiar with.
Thanks, Richard. Regina?
If I could add on I think the other piece of this, certainly, HRSA, the federal agency that gives money on workforce issues, it's important to get a budget so that they can continue to invest in that. That's a longer term issue of, expanding the workforce to reflect the diversity of our nation. But also, I think that stresses the importance of telehealth and retaining the telehealth flexibilities that we had during COVID, that we still have, but that to make sure that we can reach different areas of the country. Also, it's important where we get build partnerships, because the Wi-Fi connection is another important issue that doesn't look like squarely like an addiction policy issue, but it is. So telehealth also is another way to reach communities where they don't have enough providers, rural areas, but also people who serve diverse communities.
Great, thank you. I'm going to pause there and ask Nick and Ken and Michelle to join us back in, so we can also pick up on some of the questions in the audience, because Regina, I think that's a perfect segue. Actually, I see there are a couple of questions in the Q&A that, from people who have questions about the likelihood of finalizing more of the telehealth legislation and really securing that as part of our system. And so I wonder whether maybe if Michelle, if you'd want to come in there as well and kind of speak to what you know about that. But I just want to comment, Regina and Richard, while you started off certainly flagging where all the challenges are, and this is long, hard work, that you've also come in your comments. I hear many of the themes, also the do pick up on Michelle and Nick's comments about working across agencies, as you described. In order to get telehealth done, you also need the technology in place, or you know, working collaboratively with Department of Justice and Department of Labor, et cetera. We see that there are examples there to build on in terms of those collaborations. Michelle, what do you want to add in terms of the telehealth legislation?
Sure. So I can talk through a little bit of what we've been working on in terms of telehealth and what some of the conversations are. And I know some staffers are here and they can maybe answer some more specific questions about the bills that they're supporting. But just at a high level, you know, I'm sure everybody here is tracking very closely on the fact that the DEA put out proposed rules on teleprescribing in response to those, you know, flexibilities sunsetting with the public health emergency that allowed for those flexibilities to begin with during COVID. And we know that these flexibilities are active through the end of the year. We have advocated for evaluating the impact of teleprescribing, both from a healthcare access perspective and from a kind of criminal justice perspective. And we're hoping that the agencies in the final rule can commit to some of these evaluations, given, you know, what Regina and Richard were describing, the need for more data, the need for more research, and contributing to that larger kind of broader need for evidence and taking advantage of the natural experiment that was the flexibilities. We've also been really concerned about some of the need for engaging states. I think it was Richard who mentioned, and probably Nick as well, that there's only so much that the federal government can do. And a lot of these things rest with states. The state licenses are very much top of mind for a lot of lawmakers. And I know that that's something that we're going to be looking at closely in the very near future.
Thanks. Nick, any wanted to check if you wanted to add anything on the telehealth discussion? You're on mute.
As always, I'm so impressed by the people who actually have tried to do this. And I understand I can see just how hard it is. What I find remarkable, and telehealth would be a good example of this, is why was it that the public health emergency sort of pulled back blinkers from people? And we said, well, yeah, we actually can do these things. Was it a sort of because we were in such an awful time for so many people, that there was more of a sense of solidarity around proposals, that politics weren't allowed to get in the way quite so much, that it became a bit less of a game. But it's been extraordinary just how much progress has been made because of that national tragedy. And the difficulty is figuring out how do you do that without another pandemic or something, right? And that's where I think we just have to get the federal government in particular to work much more across agencies. It would be so helpful. And may I turn this into a question, Karen, for some of the others? I mean, there have been proposals, for example, to put ONDCP in charge, sort of the agency, pulling all of these pieces together. And for someone on the outside, that looks relatively attractive. I mean, one would hope that in the process they might remove control from the title of the agency. But is that a valid approach to put ONDCP in, or are we going to see more like this HHS sort of coordination group come from within an agency. An incoherent question that I know you'll all deal brilliantly with.
I will give our other speakers an option to
I'm
comment.
happy to respond, but I feel like Regina should answer first.
I mean, you know, I worked at ONDCP for 9 years. I mean, technically and by statute, ONDCP is in charge. The issue is, you know, the budget, I mean, you know, the budgetary authority issues. I have seen ONDCP lead on many issues. And, you know, it is a coordinating body, and it's the only entity in the federal government where you have public safety and public health sitting side by side. And so that makes it uniquely positioned to talk to other agencies. Now, that's my perspective. It's not, the issues to me were not like not getting the other agencies. It was sometimes executive office of the president squabbles with the Office of Management and Budget, for example, just to call them out. That was really the biggest challenge, but you know, technically they are in charge, but that's my perspective.
I see Richard smirking, so I'll let.
I'm not smirking. Well, you know, here's the HHS perspective, which is I think people have a misconception of what it means. I think Regina's right. There are sort of some leadership things that are uniquely put into the hands of ONDCP, and that's right. I think one forgets that it's the White House doesn't do any work. The White House leads. It's the agencies that do work, and I think that you have to remember that the lines of authority go like that. And while the coordination and stuff, I think ONDCP has a very useful role to play. I think it's not like you know, running a store. It's different than that, and you know, you need places like CMS, and you need places like CDC running their shows and doing the work that they do, because that's actually where the boots hit the ground.
Thanks. I want to pick up on another theme, and there are a number of questions that have some tied to improving access to methadone from the Modernizing Opioid Treatment Act, other approaches, and Regina, I know you led some of this as well when you were at ONDCP. Michelle, again, I'll start with you in terms of what is, and you know, what has come out of Congress in terms of potential legislation, and then ask others to join in terms of the opportunities in the coming year or so to really bring more attention to improving, you know, access delivery to methadone.
Yeah, that's a great question. So I know that there are a lot of lawmakers who are very committed to treatment access, and that methadone is a really big form of treatment. There are still some controversies that need to get worked out. And I think, you know, you would think that they fall along party lines, but they aren't falling along party lines. I think this, you know, there's a general awareness that needs to be had, both within, you know, both on the Hill and off the Hill, to bring some of that evidence and that accountability into the forefront a little bit more, to better inform that policy.
So you would say we're going to see more discussion on that this year?
I hope so. I think this is, you know, the post X-Waiver next frontier. Buprenorphine has helped a lot of people, but as the fentanyl crisis continues to rage and ravage a lot of communities, buprenorphine, I'm not a physician, so I won't speak from a physician perspective, but buprenorphine may or may not be strong enough to really treat people and get people into the recovery space that they need to be in. So I think we need to, as a country, think about what are some of the most effective forms of treatment that can address people's needs, not just kind of tick the box, saying that we've done the access, we're good. I think there are a lot of opportunities for policymakers to re-examine the ways in which methadone is accessed, and particularly the settings and the conditions of those settings, and how, stigma can play a role into, where and how that treatment is accessed, and also the circumstances under which methadone may or may not be more or less effective than other forms of treatment.
Richard? Okay.
I think it's an incredibly healthy debate that we're having right now, and I think that it's long overdue. And so I think that's all to the good. I think we have to recognize a few things and look at a couple of places to learn. First thing is pharmacies are in really bad shape these days. I don't know if you recognize, there've been strikes, they're closing, there are pharmacy deserts. So I think we need to think carefully about what the alternative what the expanded distribution system looks like is one thing. Second thing is, I do think that the international experiences, both in England and elsewhere, should lead us to be careful. That doesn't mean that the status quo is good, but as we move things, we need to kind of be super aware of the potential for unintended consequences here. And I think that, if you plunge in too quickly and you create those unintended consequences, it'll be decades before you get another shot at fixing things. And so for that reason, I think we should welcome and celebrate the new willingness to debate this, but we ought to sort of be careful in how we learn the lessons from other countries.
Thank you. Good question. Sorry, Regina, did you want to add?
Just briefly, I think it's interesting in the Senate, it passed out of the Health Committee with Republican support. And that's really the only way that, that's really having bipartisan support, which is why BPC is so important, is the only way to have sustained change. And then in the House, one of the biggest advocates is the congressman from Nebraska. And, he's taking kind of a rural approach to this. And, so it is a healthy debate. The methadone regulations, laws have been so calcified for so long. And this, like when we went in, we finally got the methadone ban rule passed. That was a big deal. Ridiculous that it was a big deal, but it was. So we're actually talking about this for once. And, I'm not sure it will happen in this Congress, but it is an important discussion to have. And we need all those other preparation as well, like to make sure that pharmacies would even stock methadone, because we're having a problem with buprenorphine. So those are, I really welcome this conversation and the movement that we've had on the issue.
Great, thank you. It sounds like it's one where certainly a lot more opportunity for work outside of the Hill, as well as what discussions might be happening on the Hill to help us get to potentially a different place in terms of methadone treatment. I know we are just at 4:15. There are some other terrific questions related to workforce. So Richard, Regina, thank you for helping us touch on those. Michelle touched on the peer support for peers. That's very much a focus right now as well. So I hope people will continue to follow that and follow the work that the foundation is doing on those issues, as well as our amazing set of colleagues and grantees and peers. So thank you, Regina, Richard, Michelle, and Nick. And thank you to my team, to Ken, starting with Ken and team, for composing, putting on this webinar this afternoon. And thank you for our audience of nearly at least 300 or so who have been listening and interacting with us this afternoon. We'll look forward to seeing you again at our next webinar. Thank you. Have a good afternoon. Thanks, everyone.
Bye.